The Philippines Family Planning Crisis. Interrelated issues requiring an integrated approach. For about 4 decades, donations from the U.S. Agency for International Development, or USAID, have been the primary source of family planning commodities in the Philippines. In 2004, USAID started to phase out its donated supplies of modern contraceptives, a process they hoped to complete in 2008. The previous government responded to this development through a program called Contraceptive Self-Reliance, or CSR, which aimed to replace externally donated commodities with domestically provided ones. But this CSR strategy failed to work, as shown by the following key indicators. First, the reduced growth of contraceptive prevalence rate, or CPR. Second, the increased unmet need for modern methods. And third, the decreased public sector share of contraceptive supplies. The contraceptive prevalence rate was growing slowly from 1968 to 2003. During the years of the USAID phase-out, CPR growth flattened. Now, it will take 160 years to reach the old 2010 target. At this rate, the gap between total demand for family planning and the CPR will become even wider. The estimated number of married women aged 15 to 49 who want family planning but are not using any modern method did not improve at all from 1995 to 2005. The slow growth in CPR was offset by an increasing population. This situation worsened from 2005 to 2010 with the addition of 1.4 million women, so that in 2010, 5.5 million married women had an unmet need for modern methods. Based on the CSR, local government spending should have increased to replace the external donations. However, local government spending stagnated, passing the burden to out-of-pocket spending by users, making it even more difficult for the poor to get FP services. To provide a more comprehensive family planning solution, several reproductive health or RH bills were filed, but most languished due to intentional delays. With the current RH bill in guarded condition, access to FP services is in continuing danger, especially for the poor. The problems facing family planning providers require a comprehensive and integrated solution. Only an integrated approach can solve the three problems associated with low use of FP services. In no particular order, these are family planning service provision, government participation in family planning, and opposition to family planning. FP is a primary healthcare service, but many avoid primary facilities because of quality concerns, both real and perceived. According to the DOH 2005 to 2010 National Objectives for Health, public primary facilities are perceived to be of low quality. Those who bypass the primary health facilities are not satisfied with their services. Diagnosis is poor, resulting in repeat visits. Medicines and supplies are inferior and rarely available. The personnel are often not available, especially in rural areas, and are perceived to lack both medical and people skills. Waiting time is long, facility schedule is very inconvenient, and facilities are run down. Service providers also need to improve how they address fears, concerns, and misinformation about the safety of contraceptives and the risks of unintended pregnancies. Providers have been shown to address issues of side effects, warning signs, and related concerns less frequently than other quality of care aspects, such as cleanliness and friendliness. The government has a long history of over-reliance on external donors for family planning resources. FP is a unique health service which involves millions of regular clients, yet government budgets are hardly adequate to provide the material and human resources needed to serve these millions, both current users and those with unmet needs. The devolution of the health system has resulted in complex and ambiguous responsibilities, which also affect the family planning program. In 2010, the Department of Health said that the implementation of national health programs at the local level has become complex due to devolution. A majority of LGUs have limited financial and technical capacity to manage health within their catchment areas. Some local chief executives prioritize projects with results that can be seen by their constituents. Some LGUs are unaware of the kind of health services that LGUs should deliver. For instance, LGUs in Ilocos Sur have not been providing communicable and non-communicable control services because health workers assumed that such programs were the responsibility of the DOH. National government, especially during the Arroyo years, has failed to promote family planning as an essential health information and service program, thereby allowing the persistence of misinformation about contraception. Last, the government has not adhered to the separation of church and state. This has allowed the spread of religious tenets into health policies, to the detriment of citizens who support FP, which includes a majority of Catholics. Opponents of family planning have repeatedly attacked contraceptives. For example, Catholic leaders such as Bishop Bacani claim that FP methods exert their contraceptive action after fertilization and are therefore abortifacients and illegal under Philippine laws. In short, almost all modern contraception is equivalent to abortion. The opponents of FP have also influenced national and local government leaders to ban or marginalize modern family planning methods. During Arroyo's term, for instance, she only promoted NFP. Hence, the DOH did not purchase contraceptives, and local government units, like the City of Manila, were allowed to promote NFP only. Because of this precedent, LGUs with conservative leaders were encouraged to ban contraceptives in areas such as Alabang, Bataan, Northern Samar, Bulacan, and other places. Finally, the opposition has blocked RH legislation, a comprehensive solution to the multidimensional problems confronting family planning. These problems are not only interconnected, they worsen and perpetuate each other. The opposition restricts or weakens the FP programs and policies of the state, making it difficult for the state to spend on material and human resources. The opposition spreads myths and misinformation, making it difficult for FP providers to address clients' fears and concerns. These integrated issues have the net result of weakening demand for and trust in FP services. An example is the case of Manila under then-Mayor Lito Atienza, who was also president of Pro-Life Philippines. He said, "Contraceptive materials actually are poison to the woman's body. You look at the internet, it's even described as a pesticide. Why should I be teaching people how to take pesticide?" He eventually filed Executive Order 003, which practically banned contraception in Manila, making it nearly impossible for FP providers to do their work. Former DOH Secretary Alberto Romualdez said that because of long-standing city policies, there have developed within the bureaucracy in the city of Manila, including the City Health Department, a core resistance to providing artificial family planning services. That is to the detriment actually of the poor people of Manila. As we all know, the policy of the City of Manila does not affect any of the population except those who live in slums who have no access to information and services. Because the poor have no access to FP services, the myths and misinformation about contraception only gets worse, making it even harder for the situation to improve. For its part, the PFPS can strengthen its important roles. First, to clarify the medical, scientific, and social grounds of a strong family planning program, particularly in relation to health and development goals such as the Millennium Development Goals. Second, to strengthen the delivery of and access to quality FP services, especially in the primary and secondary levels of public health care in all geographic locations. Third, to improve the quality of FP providers through training, periodic monitoring and evaluation, adequate FP logistics, and adequate compensation. Fourth, to train and deploy multidisciplinary FP providers to areas with high unmet need. Current itinerant teams must consciously train local capacities for FP, especially for IUD and surgical contraception. Fifth, to update and harmonize protocols in FP provision, ensuring that medical barriers are minimized and standard practice, such as the use of the medical eligibility criteria, is institutionalized. Support a strong and sustained national public information campaign on FP, explaining health and social benefits and clarifying misconceptions. Family planning is an endangered health service. For the sake of the millions of women and men whose lives are on the line, whenever the program is sacrificed for political and sectarian ends, it is necessary that family planning providers unite with all Filipinos to campaign for a national law on reproductive health.